Okay, good evening once again. Welcome all. It's another Sunday, and we are excited to have another day of Afro DX where we get a chance to discuss a real clinical case here. And so today, Seba will present to me a human DX case. So I think the time is due, Seba. Without wasting any more time, I think we can start. Seba, I think you're muted.
Good evening, everyone.
Good evening once again.
I hope you can see my screen.
Now it's the same problem. When you present, I see a green screen, but if everyone else can see the screen, I will go with the flow today.
So, can the rest of the participants see my screen?
You can see your screen.
So, welcome everybody to our Sunday Afro DX. Today, we are going to have a clinical unknown case. I'm going to present to Dr. Joseph. So, Dr. Joseph, are you ready?
Yeah, I am ready.
Today, I'm going to present to you a 28 years old male who presented with history of bloody diarrhea for 1 week.
Hey, okay. So bloody diarrhea for 1 week. Yeah, I'm just admitting some people here, but it's okay. Okay. Yeah, so 28-year-old male with bloody diarrhea for 1 week. So as usual, when we hear the diarrhea as a complaint, what we usually do is think of the time frame, and we divide diarrhea into two categories based on the time that the diarrhea is presenting. And here we have acute, subacute, and chronic diarrhea. And so acute diarrhea is the one which is less than 2 weeks, while subacute diarrhea goes between 2 to 4 weeks, and chronic diarrhea goes above 4 weeks. So this is helpful, but one should put into context that you can see diarrhea and then it is on the way into going to another category of time. Like we are seeing a 1 week diarrhea, but we don't know, will it just end up less than 2 weeks, or is just we are seeing it today, but this is the thing that will progress to more than a 4 week diarrhea, which will be a chronic diarrhea. But if I restrict myself into just acute diarrhea, usually when you sit in your clinic and someone comes, they present with a diarrhea which is less than 2 weeks. Most commonly, we just think of an infectious diarrhea, which is nothing. And most of the time, what we do is manage the diarrhea symptomatically, because most of the acute diarrhea will be of infectious etiology. But there is something else here which further characterizes this diarrhea not to be a simple diarrhea. So we are told it's a bloody diarrhea. And when acute diarrhea is bloody diarrhea, we that is a red flag. we get out of that context of saying, oh, this is just an acute viral etiology diarrhea that needs just symptomatic management. And bloody diarrhea, I don't know where this case came from, but if you read about acute diarrhea in the resource deprived areas like here, you think if you have acute diarrhea with blood, you think probably this is not just a viral diarrhea. Maybe this is a bacterial diarrhea, and we're talking about some bacteria here like Shigella. So actually, it's usually the indications of giving antibiotic to patients with acute diarrhea. But so that I will not being restricting myself. I should also consider other causes of acute blood diarrhea rather than infectious.
For you there, uh, because I can't hear.
Yes, David.
Yes, you disappeared for a while. I'm not sure if it was just
Uh,
my internet or you really disappeared.
um, which part did I?
So you were talking about bloody diarrhea in resource limited settings. I think that's where you were.
Okay. Yeah. So what I said there is when we have acute diarrhea in source limited settings where we cannot test in a go all infectious etiologies, we use it as a qualifier for an acute diarrhea that needs antibiotic. Keeping in mind that there are probably infectious etiologies like Shigella or entero something E. coli that needs antibiotic. Yeah, and after that I said so that I cannot restrict myself into just infectious diarrhea, we should consider also other non-infectious causes of bloody diarrhea, because I said maybe we are seeing an acute diarrhea today, but we are on the verge of going into maybe subacute or chronic diarrhea. So what if we are seeing a patient who has inflammatory diseases of the GI that will present with a chronic diarrhea, but they just came today to present with a 1 week history. So we should consider that and not wait for 4 weeks to diagnose them. So in the HPI, I think we're going to hear the seriousness of this disease, whether they have other symptoms like weight loss, fever, abdominal pain, etc. And of the inflammatory diseases, mainly we are talking about the IBD, which is an autoimmune disease. But again, there are other inflammations that can occur in the GI other than the autoimmune diseases. Someone with a malignancy of a GI, they can also present with a blood diarrhea at a point. So I think if I say this acute diarrhea with blood infections, most probably bacterial infections such as E. coli or Shigella, give antibiotic, or probably it's not even infectious. It's just subacute or acute diarrhea, but we are seeing it today within 7 days. But it's also an inflammatory diarrhea, probably from autoimmunity or a malignancy. The HPI will tell us. So more history, Seba.
Thank you, Dr. Joseph, for an excellent introduction regarding our chief complaint of today's AfroDX. So moving on to our HPI, this was of gradual onset, progressive, so it was fresh blood, reported up to 20 motions per day, including nocturnal motions. So it was associated with crampy abdominal pain, tenesmus, rectal pain, and fever. So the patient also reported chills, fatigue, muscle, and joint pain.
Is that all that we have, Seba?
So prior to this, there was not any history of eating contaminated food, no history of recent travel, no history of context to anyone who had been having diarrhea previously, no history of recent camping, no history of exposure to pets or farm animals. There is no reported history of antibiotic use, no history of prior NSAID use. There is no history of smoking, and there is no history of similar familial presentation. Yes, this is what we have for the HPI.
No. Thank you very much. So can you go back to the first slide of the HPI? Yeah. Okay. Yeah. Now we are seeing here that it's a 1 week diarrhea as we have been told initially, but it is not a usual infectious etiology diarrhea that we know. Let's say this was not bloody. Let's say this was not blood and it was just watery diarrhea. But if a patient comes and they tell you they have 20 motion per day, 7 days of watery diarrhea, you also can't just say, okay, we live in Africa, for example, say, okay, it's a viral etiology, manages symptomatic, tell this guy go and drink some fluids and rest, it will go away on its own. That will click in your mind that this is not normal, that someone has a 20 motions 7 days. Basically, maybe you're going to admit them and think of other serious diarrheas like cholera if it was watery. But now we are told these are bloody diarrhea, 20 motions per day, 7 days, plus other stuffs like crampy abdominal pain, tenesmus, rectal pain, fever. So I doubt this will end up to be just an infectious bacterial diarrhea just because it's an acute diarrhea. So my doubt comes because tenesmus, rectal pain, these are telling me that this patient's lower GI system is seriously inflamed to the point that he's having uh, 20 motions, and then fever shows that there are also systemic symptoms in this patient. So where am I? I would move from the context of considering this just a simple acute diarrhea with blood, which will take me into the direction of a bacterial infectious diarrhea, and considering that what we are seeing is just a part of a bigger picture. They say if you see maybe a pen falling from a table, that pen started rolling some seconds back. So what we are seeing here is a pen rolling, and maybe it will fall after 4 weeks. If this was a 4 week history, everyone would say, rule out IBD in this patient. But the thing that is telling not to rule out IBD here is 1 week. But again, patients can come at any time. So I think wherever we will end with this case, one must the of the infectious, of the inflammatory causes of diarrhea without thinking of acute, subacute, and chronic, because that will not make sense. This patient can go in any spectrum in that order. So in that category, we still have chronic infections, autoimmune diseases, and malignancy. So chronic infections like TB of the GI system can present with a fever, with inflammatory symptoms, and the diarrhea. probably not a 20 motions of blood diarrhea per day, but yes, it can be there. Autoimmunity, IBD, should highly be thought about in this case. And given his age, also he's a young guy. And lastly, malignancy. Although malignancy is a protracted history, and the patient will report blood on stools, not just 20 motions of blood, but anything can happen. So I'll be going into that direction, and the top priority is to rule out an inflammatory etiology of diarrhea in this case, without taking into context the acuteness of the disease. Yeah. Next, Seba.
Thank you, Dr. Joseph, for an excellent description. So, moving on to the review of other system, this was unremarkable. So, in the past medical history, our patient is circumvented for more than 5 years on regular ART. The latest CD4, it's 800, and also HIV viral load, the latest one is undetectable.
Okay. Thank you. So this past medical history is very very interesting, and I forgot to talk about it maybe initially. Yes. So if someone they are immunocompromised, you have to qualify their diarrhea in other sorts of way, because diarrhea in HIV patients is a different topic altogether. But you think about it, is this guy immunocompromised? You realize the answer is no, because the viral load of, I mean, the CD4 of 800 and then detector viral load, this is like a normal person, and this is the benefit of science and management of HIV that have been there since the 1990s. That these guys can lead a normal life as other human beings. So this slide will not persuade me into going down the line of thinking maybe you're dealing with diarrhea in HIV patients, and start thinking of those fancy organisms that can cause diarrhea in these guys, because this person is not immunocompromised. They're like a normal person, I can say. Or maybe we can move on and hear the story.
Okay, thank you, Dr. Joseph, again. I think that was excellent. Then coming to the family social history, he's the second born in the family of 4 children. So all other siblings are alive and well, lives with his biological parents. So he's not married, but of particular importance to note is he has a sexual history which is notable for multiple men having sex with men, unprotected and unreceptive encounters. So the latest one was about 3 weeks ago. There's no history of using illicit drugs.
Okay. So this family and social history is rich, and I think it needs a deep.
Any comment regarding the slide, Dr. Joseph?
Oh, sorry, I was muted. So I said this family and social history is important, and it in this particular patient it needs a deep introspection, because this is a young guy, and we are told they are having what we think is an inflammatory diarrhea. And one aspect that I've learned throughout my short career is that if you see young patients presenting with a serious disease, they usually end up within like three categories of people. So one of it is that their serious disease is caused by just genetics, which is bad luck, and another is that it's caused by behavior. So behavior like drugs, alcohol, and sexual encounters, as we're seeing in this patient. And lastly, just so genetics, bad behavior, and just bad luck. It's just unlucky that maybe a 20 years old presenting with MI that is so unlucky. So we are seeing a behavior here that is risky behavior, health risky behavior, that is receptive MSM. So it is telling me that what about the fact that this patient is presenting with acute diarrhea because they have rectal infections of the STIs? And then I'm trying to think of which rectal infections can present like this. So some that I know, I know gonorrhea, but I don't think if gonorrhea presents like this with a bloody diarrhea. That I doubt. I highly doubt. Uh, Syphilis can present with ulcers, but again, not at 20 motions with a fever and stuff, diarrhea. The other issue that came up recently, especially in the West, the chicken pox. Sorry, not the chicken pox, the monkey pox, not chicken pox. The monkeypox. I remember reading it in the New England Journal of Medicine the case that of a young guy with MSM presenting with a monkeypox with rectal lesions, but it was not this much. But that is easy. If we put in a scope and we can see the lesions, we can tell. Can they present with other issues? Um, I'm limited with other STIs of the rectum that can present with a protracted diarrhea. So I think I'll put this on my back and maybe later think of it when there is nothing of what I'm thinking right now, of the serious diseases I'm thinking right now that I've been talking about previously. For example, let's say CMV colitis less likely based on the immune of the patient. Yes, he's HIV, but I consider him to be immune competent right now because he's on ART and CD4 rather well. So if at all the inflammatory etiologies of diarrhea that I've talked about before, IBD, chronic infections, and malignancy will not be there in this patient, I'll take this information and think deeply on the STIs that can present with STI infections of the rectum that can present this way. But otherwise, right now, also this information is not taking me to much to a different direction. So I'll take this into consideration. Next, Zeba.
So coming to the general examination, our patient was fully conscious, is febrile, with temperature approximate 38.2 degrees of Celsius. Is not pale, not jaundiced, no oral thrush. There's no aphthous ulcer, no angular stomatitis, no lower lipedema, no palpable inguinal lymph nodes. So there are no any stigmatas of chronic liver or kidney disease. Respiratory rate was normal, saturating normal and room air. Blood pressure was also normal. Pulse rate was 97 beats per minute.
Systemic exam.
So coming to the abdomen, so our patient had normal abdominal contour, which was moving with respiration, but he had generalized tenderness, no rebound tenderness. So the abdomen was soft with no muscle guarding, no organomegaly, no palpable mass. So there was no genital ulceration or genital discharge. In the digital rectal exam, patient had normal anal veg, no rectal mass, but had rectal tenderness. And also the gloved finger was stained with bright red blood. Coming to the respiratory system, it had normal findings. Cardiovascular system had normal finding. Also, the musculoskeletal system had normal findings.
Okay, so very important. Two things that jump out that exam is a general exam which shows fever of 38 and per abdomen which shows generalized tenderness and a diarrhea that shows a tender rectum with no ulcerations in the genital area. That is very important. So taking fever for first. Uh, David has discussed some cases around here with fever and he had a mnemonic. If I try to remember it, yeah, but okay. IMAID said IMAID. Yes, the mnemonic was IMAID. I for infection, M for malignancy, A for autoimmunity, and D is for drugs, Y is for endocrine causes of fever. That mnemonic is very important because it makes you think broadly about fever. But whenever you see fever, the first thing to think about is first the eye. That eye in the eye med should be put in a in a bolded capital letter. Fever is an infection unless proven otherwise. And if you cannot isolate an infection, then you go on to the M and A and stuff. If you think of a fever and you think of an infection, you first think of the source of that infection in that patient. And most common sources of infections in patients include the urinary system, the GI, the respiratory system, skin and soft tissue, and sometimes you can have bacteremia without a source. So in our patient, we're not hearing anything from the respiratory system, so that is not the source of this fever. We're not hearing anything from the skin and soft tissue. We're not hearing anything from the genital urinary system, but we have a GI system that is presenting with diarrhea. So yes, this can be the source of infection, and I have dis- discussed that since the first of this case. But I'm being cautious not to label just this is an infectious diarrhea because of the way it is presenting, the severity of it, the age of the patient, the immune status, the well immune status of the patient. So, but I'll put aside, I say maybe it's an infection, but my mind still goes in an inflammatory diarrhea phase. So, what if we go out of that eye and move into maybe is it a malignancy? Less likely in a 20-something-year-old. Autoimmunity, I have said maybe it is an IBD that we are dealing with. And an IBD is very important here for that fact that generalized tenderness and a tender rectum during DRIE. So this tells me that all the inflammation that we are seeing in this patient is coming from the GI. So if we are seeing tenderness during generalized tenderness during palpation of the abdomen, and then a tender rectum, I probably points out to that direction that the diarrhea 20 motion that this patient is having is inflammatory. with the edge that we are seeing, and it makes us think more of we have to rule IBD at the end, but it will depend now what they will tell us on when they do a scope, if there is or no. I will have to consider other things if that will not be the case in this case at the end. So yeah, next Seba.
So coming to investigations, complete blood count was done, which revealed leukocytosis of about 16,200. HB was within normal range, 13.5. Also, platelets were normal. Renal function tests were normal. Liver function tests were also normal. Electrolytes were normal. The thyroid function tests were normal. The VDLL was negative. CRP was elevated, about 80 milligrams per deciliter. Also, fecal calciprotectin was elevated. Also, a patient was positive for chlamydia trachomatis DNA.
Thank you. Yeah. So a white count of 16 is not surprising. White count means the blood system is reacting to an inflammation, and surely this patient is inflamed. So that is not surprising. It doesn't need necessarily to be an infection. It can be anything. It can be autoimmunity, malignancy, or even an infection. Number two, CRP of 80 again. It needs consideration. This is very high CRP. So is also telling us this patient is inflamed, and the site of inflammation is the GI. The question is what is inflaming it. A carb protection of 153, again, it tells us the GI is inflamed. The GI is inflamed. It doesn't necessarily need to be IBD, although it is easy if this was a multiple choice question, you're seeing this, your mind goes into IBD, but it doesn't necessarily be IBD, but it can be IBD. And that this patient is a chlamydia trachomatis then where was this chlamydia trachomatis? Is a stool or something?
It's a rectal swab.
Oh, it's a rectal swab.
Yes.
Okay.
Yeah, rectal swab.
Yeah, so this means that chlamydia is the most common STI, by the way. It goes along with gonorrhea. So for it being there, is this the cause of all this disease? I've never read about rectal chlamydia. I've read about urethral chlamydia, and it presents the same as gonorrhea. I don't know if the rectal chlamydia present the same as the rectal gonorrhea. I don't know, but does it to be positive? Does it means is it necessarily what this disease is presenting with? If I use common sense, I think that is not the case. That someone who is MSM, receptive MSM, they have chlamydia in the rectum. Is it just there, but the disease is not related to the chlamydia? That also is highly likely. So what I will be doing in real life if I will be presented with a case like this, and these are the investigations that someone will be giving me, I would admit my limited knowledge on rectal chlamydia infection and read about it. But in this case, as we are discussing it, I'm considering both of them. Probably we are seeing an STI of the rectum from chlamydia, but it doesn't rule out what I'm still thinking of the inflammatory disease of the GI. I have no much knowledge on the chlamydia infection, but why would it cause a generalized infection, a generalized tenderness of the abdomen, for example? I I I highly doubt that. But yeah. So yes, my conclusion for this is that I don't have much knowledge on chlamydia infection of the rectum, but being positive doesn't necessarily mean it is the culprit of the disease. What we know, this patient has an inflamed GI system. Anything is possible. Highly likely for me is an IBD. I'll need more information, for example, I'll read aloud and see how this present. But knowing that chlamydia travels together with gonorrhea and how gonorrhea of the rectum present, I highly doubt it if it presents like this. But yeah, maybe we'll hear next and learn from you, Seba. Next slide.
Any other investigation that you'd wish to have, Dr. Joseph? Or you think you can commit yourself to our possible provisional diagnosis?
Yeah. So at the end, this guy is so serious. 20 motions of a bloody diarrhea, even if it seems just acute. And you are told, if you go to the indications of endoscopy and stuff, maybe you cannot put this patient anywhere. But at the end, this patient needs up and low endoscopies with a biopsy, by the way. So from there, we can see, for example, the pattern, how the inflammation is. Does it look like IBD, or how else? And can I commit at this point? Yeah. So let me say this: I admit my limited knowledge of chlamydia infections of the rectum. I put IBD first up there based on the age of this patient, the exam that was done, that is generalized tenderness of the abdomen and tender rectum, with the 20 motions, 1 week tender, 20 motions of blood diarrhea for 1 week. So I put IBD as number one. I'm not conversant. I cannot say much on the chlamydia infection of the rectum if it can present this way. But yeah, maybe it is a possibility. Yeah, to you, Seba.
Okay, thank you again, Dr. Joseph. Thank you for committing yourself. So, diagnosis, we had a diagnosis of chlamydia trachomatis, which is specifically the lymphogranuloma venereum, causing a severe rectal syndrome known as the proctosigmoiditis. So, abdominopelvic CT scan was done, which revealed a circumferential wall thickening, most prominent at the terminal ileum, cecum, and rectum. So, colonoscope revealed a 4 centimeter rectal ulcer extending to the dentate line with normal cecum, ascending, transverse, and descending colon. So, as Dr. Joseph, you have highlighted very boldly, this is the presentation which almost always resembles the IBD. So, lymphogranuloma venereum proctosigmoiditis is an important mimic of IBD. So, almost always it's very difficult to differentiate the two of them. So, this is an ulcerative sexually transmitted infection caused by chlamydia trachomatis. The specific serovas is L1, L2, and L3. And it's the most common cause of hemorrhagic proctitis among men having sex with men. So currently, a number of cases have been reported in Northern America, Europe, and Australia. So patient with LGV proctitis typically presents with rectal syndrome. There is a severe ulcerative proctitis associated with bad diarrhea, which is so significant, up to 20 motions per day, and even in the nocturnal times. So they may have mucopurulent discharge. They also have tenesmus. Also, of particular importance to note here, it is usually associated with systemic symptoms. So these patients usually have fever, generalized body malaise, and weight loss. So when the rectum is the primal site for inoculation, specifically for receptive MSM, proctitis is usually the most common reaction, and usually inguinal lymphadenopathies are absent. We usually know that the LGV, lymphogranuloma venerum, usually presents with inguinal lymphadenopathy in cases in which the primary point of inoculation is the penis or vagina. But in particular instances in which the rectum is the primary site for inoculation, we rarely see inguinal lymphadenopathy, and even the penile lesions are rarely seen. So for an individual who you haven't encountered rectal infections by chlamydia, usually it may be difficult to say straightforward this is rectal chlamydia, because usually there is not any penile discharge, lesion, or any lymphadenopathy. So LGV proctitis must be routine ruled out in in individuals who are MSM with anorectal complaints. So as Dr. Joseph, you have said, so it's very difficult to differentiate IBD and LGV. So this is a very important mimic. And even in the endoscopic findings, they usually have almost similar picture. So they may present with mucopurulent exudate with hyperemic friable mucosa, which is also seen in IBD, multiple ulceration, granulation tissue in the rectum. So they also have focal crypt distortion and cryptitis, which is resembling the typical picture of IBD Crohn's type. So you have a young male who is presenting with features which are resembling IBD, and you happen to get the sexual history that this individual is MSM. So it's very important to perform the NAT, the nucleic acid amplification test, so as you can be able to rule out LGV. Because there have been reported multiple, I've seen some multiple case reports of individuals who have been treated as IBD Crohn's type. So they've been on IBD therapy, the monoclonal antibodies, infliximab, and the so forth, for more than 6 months, and these individuals do not get better at all, only to come out and find that this is not IBD, rather than it's a very important mimic of IBD, which is LGV proctitis. So complications include fibrosis, strictures in the anogenital tract, chronic genital ulceration, anal fistula, and genital elephantiasis. And the good thing about this treatment is very cheap, very affordable, and highly available. So the treatment is allodoxycin therapy, 100 milligram BID for 21 days, or you can go as long as the anorectal symptoms disappear. So in the absence of lab confirmation of L cerebrus in areas where you can't have a nucleic acid amplification test, so individuals who fits a clinical picture of IBD but possible MSM, you have to have a presumptive diagnosis. Also, lack of response to convection IBD therapies in patients who have been diagnosed with IBD but fit the profile of LGV proctitis. NAT test should be done so as you can be able to rule out the presence of LGV proctitis.
Thank you very much, Seba, and thank you and David for selecting this case. There are so many cases in the human DX, and you decided to select this. So the most important part in this case will be my reflection. First of all, I'm happy that I missed this case because now in this Sunday 8 p.m. I've learned something new. Basically, I've seen LGV not once. I've seen LGV, but not in an electro LGV. I've seen uh, penile LGV, painful ulcers, painful genital ulcers with painful inguinal lymphadenopathies. I've seen not once. I've seen some multiple times. So I realized in this case that I don't have a proper understanding of the chlamydia infections of the rectum. So knowing your limitation in doing a diagnosis is very important part, because in real life, I'm telling you, I would never miss this, because I would just go if someone if okay, maybe I would have missed because I couldn't have an idea of sending an of sending an a chlamydia. But again, if I was presenting this in real life and I go and read about it, I would have seen and I would put it as a differential diagnosis. And maybe if, even if we would have been considering IBD, I'll give this patient doxy because it's just a short course of doxy and see if it will come up to be an IBD at the end. So it shows into telling us, all of us here, why we do this AfroDX thing and why we encourage you guys to discuss, because now I have more knowledge. Maybe one day I'm going to see someone MSM presenting this, and on top of my IBD, I'm going to add LGV. And even if I'm limited, I'm in Tanzania, I cannot send a chlamydia. I'll just give doxy on the fly, and see if the GI symptoms remain, and think of IBD later. So thank you very much, Seba. That was a nice case that I missed, but I'm happy. Yeah. Anything from the floor, from anyone want to say something, or anything from you, Seba? Anyone want to share their experience? Have you ever seen something like this? Or what do you think? What do you think? Would you have done not to miss the diagnosis I did? Yes, Alex.
Yeah. Once again, as you said, you thank David and Seba for the choice of the case. I too concur with you that it's a nice case, especially in the world we are now. We are not spared from this kind of sex nowadays, and it looks like it's a new fashion in our country now. So it's nice to know that there are diseases like that one. Chlamydia can affect that and the extent of having blood diarrhea. So it was a nice case to learn. But also, your approach, Joseph, towards diarrhea also has widened us, though you didn't click to the diagnosis straight today. But at least you you gave us a way forward on how to approach diarrhea, which is a nice one. And I can tell you, uh, those findings on the colonoscopy and they just look like Crohn's diseases.
Yeah.
uh, so you were right. You were right in those presentations. But the only thing here, the clue I think here is that the guy is men who have sex with another man, and he's a receptive part. So that's a big clue here. Otherwise, the symptom might be carried away with the inflammatory bowel disease, which is not a problem too. But now the lesson here, which I think is that we should not be worried if we get the patient like them, even if we don't have the tests to confirm them, like the DNA for chlamydia. The important thing, if it is just we know that this person is involved in sex with the other men, then we have to try the docs, as you say. That's, I think, is very important. Thanks, otherwise, for the choice of the case. Thanks, Joseph, for the discussion.
You're welcome, Alex. Anyone else? David, you just want to hear your voice, man.
Hello, everyone. I think I've missed Afro DX for 3 weeks now. So the weekend before last week, I was on the road during the presentation, so I joined during the last minutes of the presentation. And then last weekend we didn't have the session, so it's been a while, and I feel like my brain is rusting because I haven't had Joseph discussing cases, but I think I feel a little refreshed today by the discussion. So I found this case very interesting. I solved this case, I think, a number of months back, but then I archived the case to come and present it one day, and I see it as being useful today. And I thank you very much, Joseph, for the discussion. I think uh, people have learned from you, but I just need to echo a few things, new things that I've learned today, especially when you find a young person with a serious disease. The three things that you mentioned, I think I'll take that one and use it at least in solving difficult cases. So you think of something genetic, something from behavior, or bad luck. I think that was useful. So one thing that I find very useful in listening at someone thinking out loud through a case is that you get to learn from their mental representations or the way they think through a case. Because if you read in a book, it's the regular medical jargon, which is easy to forget sometimes. But I think a heuristic like that one is very easy to remember. So you find a difficult case in a young patient, you think, okay, this could be genetic. You consider all the factors, or it's so I think that's a useful one. So I think I learned a lot of things today, but that's one of the things that I thought it's worth mentioning again. But again, your approach about diarrhea in general, about bloody diarrhea, especially the acute one, the reminder about IMED, I feel refreshed. So can't wait for next weekend.
Yeah, thank you very much. And should also say that I should thank everyone here. The community is growing. People are appreciating what we're doing, and they come here. And we promised now next week, David is going to discuss a case from me. Call your friends. It will be a very nice case. I've been thinking of it for 6 months, maybe now, and I decided to present it. Maybe I have answers, maybe I don't. Yeah. So thank you, everyone. Have a great good night, and see you next week. Thank you, Seba. You are doing a very great deal on this platform because you are a resident. You have a lot of things going on, more than us. Me and David, we just see patients. Yeah. Good night, everyone.
Thank you and good night, everyone.